Hello, everyone, and welcome to another episode of the Overcoming Chronic Illness podcast. My name is Dr. Bryan Rade, and I'm a naturopathic doctor. And today is part two of me going over the Neural Zoomer Plus test from Vibrant Wellness. If you missed the part one test, I'd recommend going back and watching that because I go into the ins and outs of why we care about the Neural Zoomer Plus, what the testing is all about, kind of going through the jargon of the test, and then I go through a bit of test interpretation in that episode as well. So just for quick context, just in case you're like, I don't have time to go back and watch part one, or I'm just going to listen to part two. Totally fine. Just for context, the NeuralZoomer Plus is a blood test, again, available through the lab Vibrant Wellness. I have no financial relationship with Vibrant Wellness or any lab or any supplement company or anybody out there at all. Completely independent clinician over here. And it's just a test that I found to be really useful with my patients. I've been using it more and more. And just unfortunately, there are so many neurological challenges out there, whether it's, neurological, defined neurological diseases like MS or Parkinson's, Alzheimer's, other types of dementia, folks that are dealing with brain fog, folks that are dealing maybe with post COVID related issues, spike protein related issues, long-term effects of from neuroborreliosis, like Lyme affecting the brain, co-infections affecting the brain, mold toxins affecting the brain, kids with PANS or PANDAS and all the neuroinflammation that goes with those conditions. In my opinion, the NeuroZoomer Plus is a much more cost-effective alternative to the Cunningham panel, which is kind of has been the gold standard in lab testing for PANS and PANDAS for many moons, and this is quite a bit less expensive. It's less than half the price. So it's a really great test. Still quite expensive. It's $420 US for this test, so it's quite expensive, but quite a bit less expensive than, to my understanding, the $1,000 US it is for a Cunningham panel. So long and short of it is I found this to be really useful with my patients, and today I am going to go over a couple of reports. So in the last report, or the last video rather, I was going over a report for one of my patients who had been dealing with Parkinson's disease. The first report I'm going to look at today is a patient who has a history of MS. This patient has a history of MS and also has a lot of really severe muscle cramps and muscle spasms. And this patient, unfortunately, has had very non-existent response, unfortunately, to any standard pharmaceutical treatments and to really any of the non-pharmaceutical treatments that we have been working with up to this point. So very, very sad case, very, sad from the perspective that this patient has been putting in so much effort, so much money, so much time, and has had very, very little, really no discernible benefit, unfortunately. Now, over time, we've kind of discovered certain things, kind of some explanations as to why that might be the case, but part of that a new kick at the can was doing this NeuroZoomer Plus and seeing that there are these some significant findings here. So crossing fingers and toes that this patient's going to start seeing some clinical benefits to have all their hard work paying off. But I thought that would be a very instructive NeuroZoomer Plus report to go over because it's quite an interesting one. And then the next one we take a look at that I go over is going to be on a patient who is generally healthy. Could stand to lose a little bit of weight, some blood sugar challenge issues. This patients in their mid to late 60s, if memory serves, and they're kind of like not the healthiest person on the planet, but they're not dealing with complex chronic illness. But they're having some brain fog, some memory challenges, and so I thought it would be a use. So the next report we go over later in this video, I thought it'd be useful to go over that report because it's a little more better indication of how this report can be used for someone who doesn't have a defined neurodegenerative disorder. I don't want to say, oh, talked about Parkinson's, talked about MS. Like, I don't want to seem like it's a test that's exclusionary for folks that don't have a defined neurodegenerative condition. However, that is certainly a good, very important application of the test, in my opinion. But the next one we go over will be a little more generalized, I suppose. So stay tuned for that one later in this video. Not staying tuned for too long, and I'm going to try to not make the video too long because I always underestimate how much time it's going to take to go over these reports. So as I mentioned in the last video, one of the things I really like about the NeuroZoomer Plus is the way that it is organized. So the first section goes over all of the abnormal findings, and then the last part of the report goes through all of the findings, including everything that's in the normal range. So starting out here, as I as I believe I mentioned in the last video, when we're looking at these results, we're kind of looking for, in some cases, very specific. In some cases, we're looking for a very targeted explanation as to why we're seeing specific symptoms. And then in some cases, we're looking more for just a general sense of what's happening with the nervous system physiology. So what I mean by that is, say, in this patient, one of the things that really stood out was all of these like just really awful, painful, like just impossible to manage muscle spasms, and which doesn't really fit. Like I've treated many, many, many patients with an MS diagnosis over the years, and this patient has these terrible, muscle cramps and spasms like are just really disproportionate to what I have ever seen in any other patient with an MS diagnosis. I've treated other patients with different types of, dystonia and muscle spasms and, muscle pain and different things like that. But it's just, it's not in my experience at least, it kind of stands out like a sore thumb that like this doesn't really fit that normal picture, at least in my experience. So when I was reading through the different findings of this report, I was really looking for anything that might relate to muscle spasms. So for a patient that say a patient had an MS diagnosis, which we know is a demyelinating condition, loss of an autoimmune attack on the myelin sheath that lines the nerves. I'd be certainly paying attention to the demyelination section, which you can see here. Hopefully, you can see my little cursor. So this is the demyelination. Is that going to double click for me? Maybe not. Okay. Oh, there we go. Well, oh, geez. Well. Okay. Anyways, there's the demyelination antigen section. So certainly paying attention there. But if the patient, let's say, had an MS diagnosis and they were doing pretty well, let's say they maybe just had some mild symptoms left over, they were responding quite well to treatment, whether it's pharmaceutical treatment, non-pharmaceutical treatment, some combination, they're doing quite well. And we say, well, let's do a neural zoomer plus and see like what's the state of the union right now? How are things looking with treatment? Or patient, say, is asymptomatic. We know from their MRI and maybe other tests that yes, there is MS, but with treatment they're doing really, really well. They're asymptomatic, but are we treating enough? Are we getting some? Are we making some headway on helping to regulate the immune system response? And so the NeuroZoomer Plus could be very helpful in a case like that. So in that type of patient, I wouldn't really be looking at the different antibodies that are tested for to see like, oh, it's, they're having this symptom. So I'm really looking for antibodies that help to explain that symptom. If the patient's not having any symptoms, I'd be looking more generally at how is the demyelination section looking? How's the brain autoimmunity section looking? How's the blood-brain barrier integrity section looking, et cetera? So a little bit more generalized. With this patient where they're experiencing these really specific or very, very well-defined, sticking out like a sore thumb, like doesn't really fit normal clinic course type picture. I was really looking for hopefully a specific finding, and so we'll see coming up that there seemed to be a very specific finding, which was exciting, at least on a clinical level, to see that. And so we're, anyways, hopefully going to make some headway now that we have that additional information. So looking at this demyelination section, we can see that things are not looking actually too bad at all on a demyelination section. We see the antitubulin antibodies coming up, these anti-myelin oligodendrocyte glycoprotein, and then the anti-neurofascin antibodies. We can see they're all in the IgG, IgA column, and that magical cutoff point is we don't want anything higher than a 10. Higher than a 20 is considered to be quite notably elevated. Anything between 10 and 20 is, ideally not supposed to be that high, but it's not. Above 20 is where we start raising the eyebrows a bit more. High teens, we're starting to, there's some eyebrow raising there too, just not raising the eyebrows quite as high as when they're above a 20. So we can see here, 12.3 for antitubulin, a 16 for the anti-myelin oligodendrocyte glycoprotein, an 11.3 for anti-neurofascin. Things really don't look too bad. There are, I believe, about 6 or 7 demyelination antigen antibodies that they look for in general. And so we're only seeing 3 out of those come up, and none of them are all that high. So it's very interesting clinically interesting from the perspective that this patient has been undergoing a significant amount of treatment targeting the MS, these different immunomodulating treatments, detox treatments, things like glutathione, mitochondrial support, other antioxidants, etc., things that are vitamin B12, a number of things that normally help, in my experience, like oftentimes markedly help folks who are dealing with an MS diagnosis isn't touching this case at all. But yet we're seeing here, they're like, oh, there's actually not that much of a demyelination picture going on an antibody level. So isn't that interesting that we're, on paper at least, actually doing a pretty good job, but unfortunately clinically is not translating into a clinical benefit. So that suggests to me that we're missing something, that there's something else going on. And coming up, we'll see that that may very well be the case with this patient. So moving on to the next section here, I'm looking at the blood-brain barrier disruption. So again, nothing too crazy with the numbers, nothing in the red zone, like nothing above 20. And also, actually, circling back here, also, in my opinion, really encouraging to see that there aren't any of these IgM antibodies coming up. As a quick reminder from the last video, the IgG antibodies plus IgA, those are the longer-term antibody response. The IgM is the a more acute antibody response. I recently came up with an analogy I was using with a patient to explain this, and I think it's a good one, so I'm going to throw it out there and we'll see what you folks think. Hopefully it lands. So when the immune system is encountering something that it needs to respond to, then the IgM antibodies are kind of like the paramedics and the emergency room doctors. So, person's having a heart attack. It's like, oh, call the paramedics. Okay, try to get the person stabilized, get them on a defibrillator, put some like clot busters in their veins, get them to the emergency department, do, whatever needs to be done in the emergency department to stabilize the patient, maybe do like some emergency surgery. And then after all that's done, after all the acute stuff is done, then they're going to move to the rehab. They're going to be, monitored for a little while. They're going to start doing some rehab. They're going to, their healing journey, their longer term healing journey is going to take, weeks and months after that. So the IgM antibodies are kind of like the first on the scene antibodies, like the paramedics and the, say, emergency room doctors. The IgG antibody response is going to be that longer term like rehab. So that's the doctors and caregivers in the ICU and then at the rehab center, etc. So what's good to see here is that the IgM levels are totally normal. They're all under 10, which is wonderful. And that suggests that there's not this kind of ongoing there's not some trigger that's triggering the immune system on a day-to-day basis. It looks like this is more of a things are in more of like kind of a long-term management mode as opposed to like a more acute mode. If we see a lot of IgM antibodies, it suggests that there's maybe a toxin or there is some a microbe or like some type of a trigger that is irritating the, say, nervous system in this case in real time. The IgG tells us like, okay, the kind of the fire was set a while ago and it's it's burning at a certain rate, but there's not like active fire setting happening, like ongoing additional fire setting happening. So in my opinion, to my understanding, the IgM being normal looks really good, and it just further suggests that we're actually doing quite a good job keeping the immune system as happy as possible, at least in this context. So good to see the IgMs looking good. And so down here in the blood-brain barrier disruption section, same thing, IgMs are looking good, seeing some elevation of these IgGs. And let me see if there's anything else here. Yeah, and that's it. For the blood-brain barrier disruption, I think there's 5-ish antibodies to look at, so only 2 out of the 5 or so, not terribly highly elevated. So it'd be nice to see those, down below 10, but not looking too bad. So still likely not explaining why we're seeing these really challenging symptoms that aren't responding. Peripheral neuropathy section. So this patient does have some peripheral neuropathy symptoms. We can see here that the IgM is quite highly elevated. It's above 20, so it's in the red zone, the eyebrow raising zone, and it's also IgM. So this helps to let us know that there does seem to be something that's directly affecting the nerves, and that would make a lot of sense given the magnitude of symptoms that this patient is experiencing. There's quite a lot of pain. Now, it could very well be that it's partially related to the fact that there are these like terrible muscle spasms happening associated with a lot of pain. They're happening multiple times through the day, happening through the night. And it could very well be that it's that just kind of recurring pressure, that recurring like strangulation that's happening on those peripheral nerves that's creating these antibodies. When we look at the actual write-up here, when we see these elevated anti-GM2 antibodies, can be characterized by tingling, numbness, loss of sensation in the arms and legs, burning sensation in the feet or hands, and sharp stabbing pains. So the patient certainly has, some of those symptoms. But when we look at like what the anti-GM2 antibodies are associated with, they're associated with neurological conditions like chronic motor neuropathy, which patient probably doesn't have given the nature of their history. ALS, patient doesn't have that. It's just their history doesn't support that. Chronic demyelinating neuropathy, maybe. Demyelinating Guillain-Barré syndrome, which definitely doesn't have a history of Guillain-Barré syndrome. And so and then, that's kind of like the DDX list for that. So that doesn't really explain what's going on. Again, could be related to chronic demyelinating neuropathy because the patient has MS. So there is a demyelinating syndrome. So that could very well be explaining what's going on. With that being said, where we're seeing so much, like where we're seeing the demyelination section, like the earlier section, kind of the more the central nervous system, not the peripheral nervous system section, showing the demyelination profile looks quite good. I'm wondering if it's more of like a mechanical thing related to those muscle spasms, etc. Regardless, the plan moving forward for this patient is to work on a much more robust immunomodulating protocol. Patient's hopefully going to be starting on some stronger pharmaceutical immunosuppressive type treatment to try to like get a handle on things. And there's a couple of other irons that we have in the fire. So anyways, that being said, with the peripheral neuropathy section, there's about, again, like 6 or 7 different peripheral antibody different peripheral neuropathy antibodies that are tested, and this is the only one that came up, but it did come up quite severely, and one is enough. You can have notable symptoms with just one. Just for nomenclature purposes, when we talk about the peripheral nerves, so peripheral nerves are all the nerves that branch out of the spinal cord. So we have our brains, of course, which are collections of nerves. The brain's attached to the spinal cord, which of course runs through the vertebral column. So brain plus spinal cord is the central nervous system. All the nerves that branch out of the spinal cord to all of our our arms, legs, fingers, toes, all of our organs, etc. Those are all part of the peripheral nervous system. So that's the differentiation there. So where things get quite interesting with this case is that we see in the neuromuscular disorder section, there are these anti-voltage gated potassium channels that again are IgM in the red zone. And so this is where I got quite clinically excited to see this because I feel like it gives us an insight into why this patient has not responded to treatment up to this point and where we're maybe really missing something. So if we look at the right up here, so these voltage-gated potassium channels are membrane signaling proteins that help in various physiological processes. They help in nerve impulse transmission, so that's a big problem challenge in MS, and are also important for the release of neurotransmitters and hormones. Antibodies to the VGKC complexes are seen to be associated with varying conditions like limbic encephalitis, which is inflammation of the limbic system, which is the emotional region of the brain, including structures like the hippocampus, hypothalamus, amygdala, and thalamus. It's oftentimes, or it can be accompanied by anxiety, depression, irritability, mental confusion, and hallucinations, which this patient thankfully does. I mean, it's going through a lot. So as you might imagine, maybe sure there are some mood challenges and some anxious components, but this patient is actually, very, very, even keel, calm, cool, collected, like just very, very, very stoic in the face of everything that they've been going through for the last number of years. And they certainly don't have any signs of mental confusion, hallucinations, things like that. So that does not fit the picture. But then, as it says here, the VGKC antibodies are also associated with acquired neuromyotonia, which is characterized by muscle stiffness, abnormal muscle contractions, cramps, delayed muscle relaxation, and increased sweating. So this patient, to my recollection, does not have increased sweating, but has all that other stuff. So that's where I got quite, again, clinically excited that like, oh, this is, in the red zone. This is really notable. It's the IgM antibodies in the red zone, and it directly correlates with the symptoms that this patient is dealing with. I feel like the proof will be in the pudding. We'll have to see how things progress with this case. We'll see if the treatment, sort of the pivot in treatment, leads to an improvement in how the patient's doing. But I feel like the insight that we got from doing this test, like for that, those anti-voltage gated potassium channel antibodies, that information alone, I think was very, very valuable. So this, as I've indicated already, there's a few applications of the NeuroZoomer Plus test for patients with neurodegenerative conditions. One is to monitor, how are we doing? Patients doing really well. Are we missing anything? Let's do a check-in with a NeuroZoomer Plus. Patients aren't going to go for MRIs, every 3 months to check in on things. MRIs, if they progress one way or the other, they tend to do that slowly. So, it's like, oh, we're going to check in after a year, maybe a couple of years if things are stable, at least here in Canada, we're, on a socialized healthcare system. So if things are stable, like they're not going to do MRIs yearly if not needed. So they might get spaced out more. With a NeuroZoomer Plus, we can check that blood work anytime we want. Now, it's not a cheap test, so we're not, doing it like once a month or something like that. But we can check our progress and get more biochemical insight and kind of updates in terms of how good of a job we're doing. But then we can also use the NeuroZoomer Plus to see like what's going on here, like what are we maybe missing? Is there, if there's atypical cases like this one where it's like there seems to be something we're missing here. Well, oh, we found those anti-voltage gated potassium channels. And then, as I also referenced earlier, we also can use this testing if, say, there's a bit like I have another patient right now who is having a lot of really debilitating neurological symptoms, and yet like MRI is looking good, spinal tap looks good, CT scan looks good, blood work's looking fine. Gone to see several specialists, can't seem to find anything wrong. So like, well, we're going to do this test, and so because we want to see like, are we missing something at a biochemical level? And actually, we got those results back already, and like quite a lot of stuff lit up there. So it can be very, very useful tests when there are otherwise kind of unexplained neurological symptoms. Of course, there are going to be cases where I have another patient where, we did this test, history of complex chronic illness, did this test, got the results back, and it was kind of like the results were a little bit meh. It was like maybe there's some things we can work on here. Like there were some things that were off, but like there was nothing that really lit up like, oh, this is definitely what's going on here. So there are certainly going to be those anticlimactic cases where it's like, oh, I spent $420 US on this test, and then it came back showing, like, this isn't really giving us anything to like really confidently sink our teeth into. Although there was, not to say it wasn't useful. There were some angles. It just wasn't quite as like cut and dry as say this report, where it's like, oh, we're really quite optimistic that these anti-voltage gated potassium channels are explaining the symptoms because they can cause the exact symptoms you're dealing with. So, anyways, no test is perfect, but I think this is a useful one in the right context. All right. Man, I really thought I was going to be done this video in half an hour and haven't even got to the next report yet. So there, once again, I have underestimated how much time it takes to go through these things. So let's see here. Yeah, for the rest of the report here, the brain autoimmunity section. Yeah, let's just pay attention to the anti-amyloid beta here, not because it's relevant for this patient at all, but just we're going to talk about this for the next patient. So just maybe keep your eye on this for a moment. So the brain autoimmunity section, not seeing any IgMs here so far. Numbers are not that high, again, want it to be less than 10, 10.7, like 11.7, 13, nothing too major there. But just anti-amyloid beta. So these are antibodies that can be, so amyloid beta is the type of protein aggregate that occurs when, or peptide aggregate that occurs when, like as part of the pathophysiology of Alzheimer's disease. So we really don't want excessive amounts of amyloid beta. And so with this patient, despite the fact that they have a, many year history, I think the MS diagnosis has been like at least 10, if not 15 years old for this particular patient. So, long-standing MS diagnosis, lots of symptoms, and yet anti-amyloid beta looking very insignificant. So let's see how that looks in the next patient. And again, this patient is very mentally sharp with it, not having any signs of cognitive decline that has been reported to me or that I've observed in practice. Of course, sometimes patients don't report things, and you kind of see as a clinician, it's like, like you can tell that this patient's like not as sharp as they maybe once were, or like you assume that they're maybe not as sharp as they once were if you've just met them for the first time. But with this patient, like just very mentally sharp, and yeah, there's no signs of any like pre-dementia or anything like that I have any inkling of with this patient. So Let's see here. Yeah, so a couple of other levels. The anti-dopamine receptor 2, like, kind of getting into the mid-teens there. So maybe something a little bit more relevant there. But again, like no IgMs and just none of the levels are super highly elevated. And there are lots of brain inflammation antibodies in this section. So there, one, two, five out of I want to say there's at least 10 anyways. So that's yeah, something that does not seem to be overly surprising given the nature of what we're seeing. Like, yes, it'd be surprising if we didn't see any brain inflammation markers, but they're IgG and not super high. So again, it does look like we're doing a pretty good job actually taming the inflammation in general, but just not those potassium channels as mentioned. Then the last section here, Epstein-Barr. So when we see, to my understanding, when I see IgG to the Epstein-Barr nucleic antigen and the Epstein-Barr viral capsid antigen. That tells us that there's been a past exposure to Epstein-Barr, and that makes sense, especially in the context of MS, because Epstein-Barr seems to be a trigger for MS pathophysiology development. But where we're not seeing any elevated Epstein-Barr IgG early antigen, then that would suggest that there's not an active infection going on. So also, it's like an indication that we've probably done a pretty good job with the antimicrobials that we've used with this patient over time. Unfortunately, they haven't helped at all, but at least on paper, there's no active, viral picture happening here. So it's, not patting ourselves on the back for like doing a great job when there hasn't been any clinical improvement, because that just sucks. Pardon my crudeness there, but it just sucks. But evidently, we have done a good job, at least on paper. So very, very small recompense for not feeling any better, but at least we're getting some confirmation that, okay, it's not that we've just missed the boat or missed the mark, I should say, with like, oh, we just need like stronger antimicrobials. Like if this patient's result came back with like just this full microbial profile where it's like, oh my gosh, everything's just off the charts high, and then it would be like, oh, maybe we just were not successful with the herbs and the intravenous ozone and different things we worked with, but everything's looking pretty sleepy on an Epstein-Barr virus level. So that suggests we've actually done a pretty decent job on that front. The anti-HSV1 antibodies are highly elevated, and that's something that just happens when we have history of cold sores. And then elevated strep, very common to see those elevated, especially in a history of autoimmune disease. And then just seeing that there's this Epstein-Barr virus antigen, but again, there's not that elevated IgG early antigen, so we're really not worried about that. So that is that report. Moving on to the next report. So again, this patient generally healthy. Okay, so patient is somewhat overweight, a bit more sedentary than is ideal, though they're working on it. Some blood sugar dysregulation. They're on some blood sugar control medication, and then having some mild memory and cognitive impairment. So not the healthiest person on the planet, but they don't have a history of complex chronic illness, and they are just, I feel like, representative of your, I don't know, I guess you're kind of like classic person who's like not doesn't have a history of complex chronic illness, but they're maybe haven't taken the very best care of themselves leading into their 60s, and they're having a bit of cognitive impairment. So I feel like this is probably describes a lot of people that are out there, and so this is how a Neural Zoomer Plus can apply to a patient like that. Now, with that being said, I mean, this patient is doing good things, like on like there's additional good things that they're doing, such as like having a good like they have a good meditation practice. They go for regular body work. They eat organic food. Not always making the best choices around like portion control and steering away from carbs and things like that. But eating like generally like organic food and things like that. So they are making they're not the standard North American individual. They do have certainly more things going for them than the average person, but I still feel like they're fairly representative of folks in that demographic category. All right. So, yeah, demyelination section, seeing that antitubulin. Honestly, I've looked at a lot of these NeuroZoomer reports. Antitubulin comes up all the time in the IgG orange section. So I certainly pay attention to it, but it's not. It's rare that it doesn't come up. So it seems to be a low-hanging fruit for the immune system to start reacting to. But again, only one of the several demyelination antigens. I'm really not worried about that at all. Taking into account that, like, okay, there's a little something there, but not not like this notable notable demyelinating picture going on. Blood-brain barrier disruption. Um, so, only a couple of markers coming up here, but just interesting that they're both IgM. Now, levels are quite low. 10 or above, or 10 or lower is considered normal. So they're only at an 11 here. But again, this patient's generally healthy. And then we're trying to, as, Wayne Gretzky said, you want to skate to where the puck is going. So if we see that, like, okay, there's some IgM here, then why is that happening? And like, what might this lead to? And so, especially where it's those anti-glial fibrillary acidic protein. So, as it says here, the glial fibrillary acidic protein is a structural protein present in astrocytes and other glial cells that is found only in the central nervous system. Astrocytes are part of the blood-brain barrier. They're these little like, supportive cells. And then those anti-GFAP, the anti-GFAP antibodies are produced during disruption of the blood-brain barrier. Brain injury can lead to that. And then autoantibodies to this protein are found in relatively consistent levels in healthy individuals. However, its levels are high in patients with neurological conditions like multiple sclerosis. Um, so it's the type of thing with this, it's like, well, seeing where the levels can be elevated in healthy individuals, that's great. But just seeing, well, not great, but like good to know and be not like too concerning. But just seeing that there is that IgM component, it's like just thinking like, well, what is it that's maybe kind of like irritating or ticking off that blood-brain barrier? Like what's kind of ticking off those astrocytes? And so it's suggesting that we're maybe missing something. And as we see coming up here, I think it ties into some of the future results here. Microglia are the immune system cell, like the main immune system cell in the central nervous system. And when those get activated, it creates inflammation. So peripheral neuropathy. So this patient, one other thing that's going on with this patient is a bilateral leg weakness that's been going on for quite a long time. Seems to be largely related to a back injury and some muscle deconditioning over time, but it has been notoriously persistent. And so just seeing these peripheral neuropathy antibodies, especially where they're IgM, it just kind of raises eyebrows a little bit, being like, like it looks like there's something going on there on more of a peripheral neuropathy level. So telling us that like we want to probably be looking at settling down the want to looking at some settling down the immune system, kind of getting some immunomodulation in there because it looks like there are some things that are brewing a little bit there with those peripheral nerves, but nothing too major, and only a couple of items that are elevated. So the big thing, so now we're in the brain autoimmunity section. The big thing that I honed in on with this patient is seeing elevated IgM for that anti-amyloid beta. So if you remember from the last report, the anti-amyloid beta was a little bit elevated IgG wise, but the IgM was fine. In this patient, the IgM is quite elevated at 22.7. And so that gets me worried is too strong of a word, but I'm paying very, very close attention to that 22.7 because, again, skating to where the puck is going, we can kind of see the puck maybe heading towards a more of an towards a potential Alzheimer's future, which we don't want. We're starting to see some initial signs of that. It's been kind of brewing for the past few years, and so we really want to get on top of that like white on rice. So if we look at the right up here for the anti-amyloid beta, so Alzheimer's disease, one of the most common neurodegenerative brain diseases, is characterized by plaque formation. These plaques consist of amyloid beta peptides. Amyloid beta is a shorter variant of the amyloid beta peptide. It's seen to exert neurotoxic effects in Alzheimer's disease by various mechanisms, resulting in its progression. Patients might experience symptoms like memory loss, mental confusion, and cognitive impairment. Antibodies to amyloid beta, particularly the 25 to 30 length, have been shown to reflect mild to moderate Alzheimer's disease dementia. So really want to pay close attention to that, really want to get those levels down. Now, what's been good to see is that this patient has been seeing cognitive benefit to working with methylene blue, which is something that's really good for the brain. Not an immunomodulator to my knowledge specifically, but methylene blue is very good for the mitochondria. It has a high affinity or tropism for the brain. My goodness, my battery is, oh boy, dangerously low. Okay, I'm going to pause the broadcast here for 1 second while I plug in my computer. Just 1 second here, folks. Right. After that brief intermission, we're back. Um, so, methylene blue has a high affinity for the brain, and it's very, very good for the mitochondria. Mitochondrial dysfunction, or poorly functioning mitochondria, are associated with the pathophysiology of different autoimmune conditions. Autoimmunity, of course, being characterized by notable immune system dysregulation. And so, even though Alzheimer's is, to my knowledge, has not been classified as an autoimmune condition, we can see here that these antibodies that are coming up to amyloid beta, due to the presence of amyloid beta, are certainly related to they're related to mitochondrial dysfunction, related to immune system dysregulation. Like immunomodulation is super important for helping to regulate neuroinflammatory processes. And more things popping up on my computer here. Goodness gracious. Okay, I do not want to restart my computer right now. That would end the broadcast. Be no bueno. Long and short of it is that thankfully this patient is seeing improvements with the treatment strategy we're working with. We are implementing some other things as well, and we're planning to do this test again in a few months or so, maybe 4 to 5 months, to see how things are looking. So hopefully we'll see that anti-amyloid beta coming down, and we'll see further clinical improvements. But I feel like this test, even though at the whopping price of $420 US, very, very valuable, because it's really kind of honed us in on hopefully nipping something in the bud before it's becomes a notable problem. So moving on down here, these anti-rage peptides, this came up with the other patient as well. I didn't hone in on it, but this is interesting. And actually, I mean, I'm glad to see the levels are only as high as they are. 13.9 is not super high, but the anti-rage peptide, which is like just such a funny acronym because it sounds like, okay, this is like an anger management related antibody, but it is rage being an acronym for nothing to do with anger at all. It's the receptor for advanced glycation end products. And so, which has to do more with like blood sugar dysregulation. Now, the anti-rage antibodies are seen in patients with Alzheimer's disease, as it says here, and this is something that's related to blood sugar dysregulation. Some folks listening, you may have heard of Alzheimer's disease being referred to as type 3 diabetes because of the huge link between poor blood sugar management and Alzheimer's disease development. As it says here, the action of the rage-mediated amyloid beta deposition at the blood-brain barrier is higher in Alzheimer's disease patients with diabetes. So this patient is doing a pretty good job controlling their blood sugar now with medication, but there was, swaths of time where the blood sugar was not being well controlled. So I'm happy to see that levels look as good as they do. Would have been interesting to have a baseline during the periods of having less well-controlled blood sugar, because the levels might have looked higher and it would have been interesting to compare, but we'll just, continue to keep an eye on that. Hopefully those levels will keep coming down. In the brain inflammation section here, like nothing, like, little tiny blip of anti-dopamine receptor 2, and that's it. So just a very good example of like how, yeah, he's like not a sick person. He is a generally, person who's in decent health, could be a bit better, working on his health, doing, again, good things with diet, like, healthy, like organic food and different things like that. And just seeing like, yeah, there's the brain inflammation profile is nil, very, very boring, as it should be. So far the patients that we've looked at are, the other two patients were both individuals dealing with neurodegenerative conditions. Yes, there seems to be some preliminary signs of, writing on the wall that maybe there's an increased risk of Alzheimer's coming up, but no, like, frank neuropathological conditions happening right now. So good to see that brain inflammation section looking really good. In all fairness, the patient has been working with various supplements over the course of time, which can help to tone down inflammation in the body. So that could also be influencing those results too. Maybe they did look worse before, but they're anyways really looking quite good right now. And then infection-wise, we see that Epstein-Barr nucleic antigen coming up. We see the viral capsid antigen, and then we see this other indicator, just a basically Epstein-Barr antigen, but we're not seeing that early antigen. So we know there's been an exposure to Epstein-Barr virus, but no active Epstein-Barr. Strep came up. So most of us have probably had strep exposure at some point. It's not greater than 30, which is what I see in a lot of patients, but being down at 22 makes sense. It would be lower than average. we've gone down, me and one of my colleagues have gone down the rabbit hole of looking at the research literature, and we just cannot seem to find anything that really tells us like what to make of those elevated strep antibodies, save that we know from animal studies that the more strep an animal has, the greater the risk of there being of autoimmune brain antibodies later on in life. So I think it's a very relevant finding, but the fact that he's a 22.4, I don't really know exactly what the relevance is of that, because I can't find any research literature to tell me what the relevance is. And then he's had some cold sore virus exposure, but yeah, levels like super, super low. So it may be that he's just had exposure and I don't know. It's the level's super low. The other patient was greater than 30. Very little activity there. There are some interesting studies looking at the significance of having anti-HSV1 antibodies, or like having, I should say, looking at the relevance of having HSV1 virus, like herpes simplex virus 1, cold sore virus causing virus, in the central nervous system, and it being related to the development of different neurodegenerative processes. Yeah, not sure what it doesn't look like there's a whole lot of that antibody activity happening with him. So it looks like he's been exposed, but just has maybe never had a cold sore in his life. I didn't think to ask him, so we had too much else to talk about during that day. And then, yeah, just further down here, it's just the breakdown of all the many antibodies that are tested. So as I said earlier, like with demyelination antigens, there's 6 of them there. So, just mild level of 1 of 6, blood-brain barrier, okay, 2 of 4 coming up there. So again, very low levels, but just, again, kind of thinking where the puck's going to be going. Section on optical and autonomic nervous system disorders. Didn't have any of those come up. Peripheral neuropathy. So there's the 5 that are looked at there. So just little lower levels of 2 of the 5. Neuromuscular condition. So this is where in the patient with MS, those anti-voltage gated potassium channels came up and lit up like a Christmas tree with the IgM. The brain autoimmunity, so quite a few of those suckers there. That's like what, maybe 12-ish or so. So then seeing the amyloid beta there, didn't see the other amyloid beta come up, which is good. Didn't see anti-tau come up, which is another component of the beta amyloid. So again, just suggesting that things are still like very early. Like that's why I didn't say to him like, you really got to get your affairs in order. Like it's just something. Yep, there's still lots and lots of room, like lots of time, I think, for us to work on this as long as we get on it aggressively. And then brain inflammation section. So there's 3 there, and yeah, so I guess maybe about 10-ish in total. So just seeing that one little blip with the antidopamine receptor, and then just myriad viral markers. So that this is that early antigen marker that didn't come up in this patient or in the other patient. So that's why if that was elevated, it's like, oh, there seems to be some Epstein-Barr virus, either chronic Epstein-Barr or reactivated Epstein-Barr. Does not seem to be the case in this patient. And that is the report. So I hope this was of interest. I am planning to do some future podcast episodes about some other test profiles. Vibrant Wellness has a panel called the Autoimmune Zoomer, which I've been running on some patients in select cases, and that's been interesting and very helpful in some cases. So I'm planning to talk about that. There's a couple of other panels they offer, and then there's some other tests that we do from other labs as well that I think would be interesting to go through. So if this type of content is of interest, please consider posting a comment on my YouTube channel if you're watching this on YouTube. I don't really know how comments work with podcast platforms like Spotify and different podcast media, but feel free to pop me off an email, let me know, go to my website, and the link is in the podcast description, and the YouTube channel. If you want to send a comment and just let me know, like if there's a test you'd like me to go over, if you enjoy this type of content, please let me know, because I can tell based on the number of views and likes, what feedback folks give, but hearing that direct feedback is helpful too. Just a reminder that I do have a newsletter. I very, very rarely send out messages, but when I do, it's about things that I'm excited about, things I'm learning in practice, like new things that come up. So you can sign up for my newsletter there's a link in the description of the video on YouTube below, or in the podcast description if you're on a podcast platform. And then also when you sign up for my newsletter, you do get access to the first 2 modules of my Overcoming Chronic Illness course for free. So there's an introductory module and a section all about mitochondrial dysfunction. And that's something you get free access to if you sign up for my newsletter. So, again, hope this was of interest, and I will leave it there for now.